Thanks. I think we'll get going slowly because I have a feeling that there is a lot of content and that there will be lots of questions tonight. Welcome to our November webinar on exploring infectious disease consultation needs in the RAAM clinic with Dr. Philip Dwek. I will start with our land acknowledgement. We acknowledge that the lands on which we are hosting this meeting include the traditional territories of many nations. The work of Medify and our partners takes place on traditional territories of the Indigenous nations who have lived on these lands since time immemorial. Medify is located in Toronto, on the ancestral homelands of the Huron-Wendat, the Anishinaabeg, the Mississaugas of the Credit, the Haudenosaunee, and the Atawendurons. This is Dish with One Spoon Treaty Territory. Medify is committed to reconciliation. We recognize that the many injustices experienced by the Indigenous peoples of what we now call Canada continue to affect their health and well-being. We respect and embrace the rich cultural and traditional practices of the ancestors. We invite our partners to reflect on the territories where they are situated and to join us in committing to gaining knowledge, forging a new culturally safe relationship, and contributing to reconciliation. And I will mention as well that this is National Addiction Awareness Week. And thank you for the work that you do. And thank you for joining us to keep learning together about how we can improve care for people who use substances. So a little bit of housekeeping before I introduce Phil. Again, please a reminder to put your comments in the everyone section of the chat box. In the last 30 minutes, if you raise your hand, Lori can unmute you and you can ask your questions directly. Otherwise, I'll be keeping track of the questions and posing them to Phil as we go. And I don't think I need to remind everyone to put themselves on mute, but I will say it anyway and remind myself as well. There's a session evaluation that will be in the chat towards the end of the session. Please do complete that. That's really helpful for us. A thank you always to our webinar series committee members who helped to create this lineup. And we are approaching the end of our year. December, join us with Jonathan Bertram and Marilyn Campbell-White to talk about, that's a good chance for me to stop sharing, substance use care with a focus on alcohol in the elderly and a little bit of a teaser or quick start for the holidays on Mary moderation. It is my pleasure to introduce Dr. Philip Dwek. He is an infectious diseases physician at Women's College Hospital. He completed his infectious diseases fellowship at Rush University in Chicago, followed by a one-year fellowship in tropical medicine at the University of Toronto. He trained in internal medicine at Western University, where he also continues to locum. In addition, he works part-time at HQ Clinic in downtown Toronto. That is a lot of different roles. Dr. Dwek has a strong passion for medical education at all levels of training and recently completed a master's in education at the University of Toronto, and he is extremely enthusiastic to be here tonight and share some of his knowledge with us. So welcome, and thank you so much for being here.
Thank you. Thank you. Okay. So let's just make sure this is working. Everyone can see the screen. Thanks so much for that introduction. Hi, everyone. My name is Phil. So today I'm going to be talking to you about infectious diseases. I am receiving an honorarium for the talk. I have no other financial disclosures. Simply put, we're going to be talking about some skin and soft tissue infections. We're going to talk about some mimics, venous insufficiency. I'm going to talk about some sexually transmitted and blood-borne infections, including Hep C, HIV, and syphilis, and hepatitis B. And kind of just discussing a few things where consultation with infectious disease may be worthwhile. Um, all these topics I actually have separate 1, sometimes 2 hour lectures on their own. However, I'm hoping by giving like a variety of stuff that maybe there may be something that stands out to you and you want to ask a question about it. I will take any question. I love talking about this stuff. There's a lot to know. And I'm hoping that people will leave this with actual practical things they can use tomorrow when they're seeing patients. So I would like to start off with what's called a Slido. So Not everyone can do this, but if you're looking on your computer screen, you can use your phone to go to that QR code. And this is anonymous, but if someone wants to pop up there, it'll come on the screen, nice and neat. What challenges do you face managing infections in RAM? So in your clinics or wherever you work, if people could put one or two things that maybe they find challenging, this will give us a bit of a few things that maybe I can keep track throughout the talk, although I do have a variety of things I'm going to mention anyways. But I would love to hear from you guys. So I have diagnostic, work, tests, blood, maybe getting blood work, no swabs, maybe not access to a swab. So maybe limited diagnostics, and that makes sense. They're seeing people with maybe in a resource limited setting or don't have access to blood work, connecting them to primary care. Dressings, if someone does have a wound, what do you do from that? Follow up, right? So, we know that sometimes it may be difficult for people to follow up for a variety of reasons. Knowing what best antibiotic, peripheral swelling. Someone mentions work here. Maybe it's people taking time off work, time constraints, no supplies, and then hesitant to go to the ED when it's actually needed. Extensive paperwork. This is fantastic, guys. Well, this is great. Let me think I'm missing anything here. Okay. All right, guys. This is perfect. People don't go for blood work, restricted IV access. Okay, fantastic. Fear of venous puncture access. Okay, great. So, cellulitis, what it is and what it isn't, we're going to be talking about. So, trying to avoid unnecessary antibiotics in frontline care. So, I'm hoping we're going to go a few scenarios which can actually make you think maybe we don't need antibiotics, especially if it is difficult to get some. So, guidelines on skin and soft tissue infection. Last big update was actually all the way back in 2014. But to be honest, not too much has changed. When we're dealing with cellulitis, which is an acute spreading infection of the skin and subcutaneous tissue, it's characterized by erythema, it's redness, warmth, swelling, and tenderness. The key with this is acute onset. So sometimes patients may have a wound, but when you're really thinking about is this cellulitis infection of the skin, we're usually looking for a relatively sudden onset. And so some tips for this is you're thinking about portal of entry. So was there any trauma? So was this from an injection site, a mosquito bite, an ingrown hair? Do they have underlying skin conditions like psoriasis or eczema where someone it's kind of breaking the skin, they haven't been able to use the creams they previously were on, they're scratching in a particular area? Or something as simple as new shoes. And this is actually something I would see very common in patients living with diabetes where they have neuropathy and are able to have this proper sensation so they can get injuries and not notice it. So I want to go over a quick case here. This is kind of maybe the standard one we would see with cellulitis. We have a 38-year-old female with right foot and leg pain. They had chills, nausea. They vomited twice. They noted redness on the foot that spread up to their leg. They do have a history of psoriasis, and they ran out of their beta-methasone cream months ago. Their vital signs show that they're tachycardic at 120, temperature 38.5, and their blood pressure is normal. The right foot is swollen, red, painful on palpation, and you are able to get labs. You see a WBC count of 18 and a CRP of 85. And so this is what this patient's leg would look like. Now, this is a different picture, but something like this, we would see someone with psoriasis and not on their medications. So this would actually be the kind of quintessential case of cellulitis that I would say, wow, this is someone who needs antibiotics. And in this situation, if you would refer this patient, ideally refer. I'm not saying it's always easy to do this, but in this situation, you would at least offer a patient to go to the emergency room. And if you were to start an intravenous antibiotic, what would you want to start? And people are seeing a few options here: piptazo, cefazolin or ceftriaxone, meropenem or vancomycin. And with simple cellulitis, cefazolin or ceftriaxone, there's a cephalosporin, which is kind of equivalent in this situation, would be cephalexin or Keflex as the brand name, would be fine for cellulitis that does not involve an abscess. Now, one of the things I want to highlight here is that sometimes people can have cellulitis and it can turn into an abscess. And so if you look on the left here, this is something that we call phlegmon. And phlegmon could be a very puffy, swollen tissue that can sometimes, not always, turn into an abscess. Why am I telling you about this? Well, I want you to think of a situation when maybe some of us, when we were teenagers and we had pimples. Before a pimple is ready to pop, it's kind of in that red, tender phase. And then a day or two later, it's a whitehead and it pops. This is one thing you might actually instruct your patients if they do develop cellulitis, saying that if an area gets very painful, if you do notice a little bit of pus, getting rid of that pus will make this resolve. Now, ideally, this can go under incision drainage, but honestly, sometimes I've had patients who say, get that pus out yourself, squeeze it out, drain it out, and this will resolve things. But this is just that phlegmon doesn't always, but can turn into an abscess. And on the look on the right here, this is a patient that had 2 weeks of oral antibiotics, came to me. I made a very small incision and I got a significant amount of pus in there. This resolved within like 2 days after. In terms of classification of cellulitis, we kind of have three things based on our guidelines. One is no signs of SIRS, meaning stable vital signs. They're not tachycardic, their blood pressure is okay, they don't have a fever. And honestly, when I see someone with what I'm concerned about a skin or soft tissue infection, I ask questions like, are you eating and drinking? How do you feel? When I am deciding if does this patient need intravenous antibiotics. SIRS, so high fever, tachycardia, those are generally patients that are quite sick, and generally we'd want to be able to give them IV antibiotics. I can't give a talk without mentioning the severe form. And what we're thinking about is rapid progression, especially for unstable vital signs. So usually there's pain out of proportion, like extreme pain from a wound. We do want to think about a necrotizing fasciitis. And why this is so important is this is the classic flesh-eating disease, most often caused by group A strep, is higher in patients with a history of intravenous drug use or active use. And this is urgent surgical consultation. So these are the people we want to say, listen, you're going to lose that limb unless you go to the hospital immediately. So there's guidelines on this. You see this chart, it is overwhelming. But only thing I want to highlight here is if you look at the top where it says non-purulent, moderate to mild, and look at the antibiotics they give. None of these cover MRSA. So what I'm saying is that if you see someone with cellulitis without frank pus, your Keflex, your cephalexin, even penicillin probably be okay. I would say probably cephalexin is probably with a standard drug. Easy, most pharmacies hold it, which would work just fine. And we will talk about when you look over the right side, this says furuncle, carbuncle, abscess. We are thinking about MRSA, which is more common in the community these days. And we do know that patients with a history of substance use are at higher risk. The one thing I don't love about these guidelines is that they're assuming that you've made a correct diagnosis. And this is something that I'll say is very challenging, and I will talk about it in some later slides. But about 1/3 to maybe 2/5 of cellulitis cases or cellulitis aren't actually cellulitis, they're mimics. So things to think about. Is there a portal of entry? Do we know how this could be cellulitis? All we're looking for is a break in the skin. Is the leg red? And I would argue, are both legs red? Because if both legs are red, we're questioning the diagnosis. It's very, very, very rare to have bilateral cellulitis. We're also asking about the chronicity. So was this actually just a day or two, or has this been there for the last 4 weeks? Again, with chronic symptoms, I'm leaning towards this being an acute soft tissue infection and probably doesn't need antibiotics. And then thinking about some mimics, we'll talk about a few in this talk. So, when I mention this portal of entry, is what I want you to think about is bacteria loves blood. And I instruct this to a lot of my patients, especially patients with a history of intravenous drug use. I say is, listen, if you do inject, you really want to cover that area up and stop the bleeding. We are covered with bacteria. That causes no problems at all, unless we give it an entry into our bloodstream, so we're bleeding. So bacteria likes blood. One way to kind of highlight that is that when we actually take pus, so let's say you do have access to a swab, someone has a pus wound on their foot, on their arm, you get a swab there. We actually grow it on sheep's blood. And you say, well, what's the significance of that? Well, bacteria loves blood because it's full of nutrients. So those nutrients are great for our bodies, but it's not great for the bacteria. So thinking about bacteria loves blood. And you have an open wound, that is a portal entry. So we want to keep those covered if we're able to. But in general, less bleeding, less bacteria sticking and has a chance of getting in there and potentially causing something serious like a bloodstream infection. So, in terms of if you do have access to a wound swab and you want to take a wound swab. So, this is a patient that was referred to me with on antibiotics IV intravenous for 2 weeks. And you can see here that there's a little bit of redness. There's some black areas and necrosis, but there's nothing really to swab. And this would be a situation where you would not want to swab. This patient actually had significant peripheral vascular disease. This is all ischemia with maybe some local inflammation. Does not require any antibiotics, but needed to see a vascular surgeon. This is a patient with diabetes, had ongoing pus from this third toe. X-ray showed an underlying bone infection. This would be the perfect situation of getting a swab. And for this patient, it did come back growing group B strep, an organism that we actually can treat with amoxicillin. But now we've narrowed this down, and this would be the perfect situation to get a swab. MRSA. So we know that this is more common in patients with a history of drug use, specifically intravenous drug use. But even we have this commonly in community settings more than we used to. And what do I think you should know about this? So one is if we do have MRSA, and the way I would say this is, let's say you might not able to get a swab on your patient to check for them having MRSA. If you have access to Connecting Ontario and they've been colonized with MRSA before, and they're specifically presenting with new abscess, you need to think about and you should be covering for it. It's beta-lactam resistant. What that means is amoxicillin, penicillin, cephalexin will not work. The drugs of choice will generally be sulfamethoxyl trimethoprim and doxycycline. So we know it's common in this population we're discussing. People with chronic wounds are at risk, frequent visits to hospitalizations and being in crowded settings. When you think of abscess, you need to think about MRSA or purulent cellulitis, which essentially says you have an abscess with surrounding redness, a surrounding skin infection. It does colonize the nose, the nares, the axilla, groin, injection sites. And we actually do have a decolonization protocol that we sometimes will do from the infectious disease standpoint when we do have people that are getting recurrent infections related to MRSA. The number one thing we want to do with those is drain them. And so sometimes it could be as simple as popping it out. Ideally, if we have an incision and can properly drain it. But these things, if there's an abscess, antibiotics are often can be futile unless we drain the pus. Now, the big concern with MRSA is that it can go deeper. So it can be a skin infection that can cause bacteremia. That bacteremia, bacteria in the blood, then it can go in heart valves. And then from there, it can be spit off and go into the spine and get osteomyelitis, especially with persons with a history of intravenous drug use. So I guess the take-home message is that if someone's coming in with an abscess for 2 weeks and says fevers and chills, we need to think about this patient being bacteremic, and this could be a life-threatening condition. And that would be the conversation you want to discuss with them, saying, listen, this might be a situation that you could die if you don't get evaluated in the emergency room. So in those situations, we would want to get blood cultures and ask about systemic symptoms. Early infectious consultation for Staph aureus bacteremia, which MRSA, has been shown to reduce mortality and prevent relapses. And the bottom line is we're trying to get source control, so drain that abscess, give targeted therapy, and prevent bacteria in the blood from spreading to other places if we do suspect someone is bacteremic. One thing I forgot to mention was actually on my first slide of this whole talk was one of the things I can't stress that if you're checking blood work or you have some patient that's sick and you're going to follow up is you've got to check that phone number. Now, this may be something that's very common to many people, but I will actually call the phone number in front of the patient and I will try to get a collateral phone number with their permission in case I do need to communicate results. I just think that's one thing that's important to discuss in some of the clinics that you guys are working in. Okay, so takeaways from this, focus on drainage and source control for abscesses. We try to reinforce hygiene. And I would say that's trying not to share things with other people. Wound care, which is trying to keep something covered. If there's blood, try to hold pressure to stop the bleeding. And if someone's getting recurrent MRSA infections, there are obviously maybe other issues going with the patient, but like in terms of trying to get them stable from a substance abuse standpoint. But we do have decolonization protocol. I won't go into it too much right now, but I'm happy to take questions about it after. It does involve washing daily with chlorhexidine. But also in terms of don'ts, we don't treat every leg for MRSA. In fact, if it's just cellulitis without abscess, giving cephalexin or if it does need intravenous antibiotics with cefazolin is fine. You don't need to start empiric MRSA treatment. And then also, we want to continue antibiotics unnecessarily after clinical improvement. So once someone's resolved their wound and they're feeling better, usually 5 to 7 days of antibiotics for, let's say, cellulitis is fine. We don't have to treat till the redness goes away. That can take weeks. What about antibiotics for all abscesses? So this has been studied, and if you have an abscess that's like less than 5 centimeters and it's drained, there's good evidence to suggest you don't need further antibiotics. Now, things to think about is that if the patient has systemic signs, so they say they have fever or felt feverish with this, probably would have a low threshold to give doxycycline or sulfamethoxyl and trimethoprim. Multiple lesions, multiple abscesses, probably a better reason to give antibiotics. If they're immunosuppressed, so if they're living with HIV and their CD4 count's low, I'd have a lower threshold to give antibiotics. And if it's an involvement of area that's difficult to drain, so let's say it's in a genital area, it's somewhere on the face, in those situations also would have a low threshold to prescribe antibiotics. Take-home points of skin and soft tissue. Look for the nidus. Does the story fit? Acute soft tissue from a break in the skin. Onset should be days, not weeks. Are they sick? That will help me decide intravenous versus oral. And then cellulitis, just think about it. Could be just cellulitis, phlegmon, but it could turn into an abscess, and to discuss that with patients. And if they have an abscess, known MRSA in the past, we should then cover for it. Okay, guys. So next case, 74-year-old female with right arm cellulitis. Now, some of these are a little sneaky, but we're here to learn. So this is a 70-year-old female, 74-year-old female that snorts cocaine regularly. Recently, though, they did decide to inject in the right antecubital area. It was swollen. They were systemically well. They were applying polysporin for about 5 days and noted that the area became very itchy and there was spreading redness in that right arm, and they were seen in the emergency department. They did have some labs done, which were largely unremarkable, and a CRP, which is a very sensitive marker for infection, if it's over 5, was completely normal. So this is what their arm looked like. They said it was very itchy. So this is anonymous. If anyone cares to indulge us, what would you do? Would you start them on oral Keflex, cephalexin or Keflex? Would you start intravenous IV ceftriaxone? Would you give them doxycycline? Or would you give no antibiotics and give topical steroids or Benadryl? Okay, and we'll wait maybe one more response. Okay, great, guys. So this is a sneaky case, and it's probably more common than we realize. This is actually allergic contact dermatitis from polysporin. If I hadn't seen it so much, I wouldn't know about it. But allergic contact dermatitis is inflammation of the dermis and epidermis as a result of a substance on the skin. It is divided up into irritant and allergic in terms of contact dermatitis. So irritant is immediate inflammation. This is kind of more when, if you might remember, if or might have seen, if people are doing alcohol on their hands, like exceedingly, it can be very dry, cracked, and fissured. But allergic is usually delayed by days. Other things just think about is the location usually is on the hands because it could be from dish soap or excessive alcohol. People even may describe this as burning. This is, yeah, dry, fissured. And the allergic, so on exposed areas of skin, which can be on the hands as well. Pruritus is dominant. They may see some vesicles or bullae, which we saw in our patient, usually can have more distinct angles, lines, or borders, and we can sometimes see urticaria. Interestingly, there's a case from CMAG where someone was applying it on their lips. They had a history of HSV and then started putting some polysporin on. And the active ingredient that generally causes this is actually bacitracin. This was a study out of Ottawa where they actually used a bunch of topical ointments and found that bacitracin was the most allergic. People have the most amount of allergies is to bacitracin. So, what about polysporin? We always learn to put us on a wound if there's a wound that's present. It's important to note that all wounds will be colonized with bacteria, and generally topical antibiotics are recommended after like a laceration repair. So, if someone went for surgery, they cut the area open, we would then consider it. There's actually very limited evidence for small cuts or wounds. Another example, this was a patient I saw who actually cut her finger when she was cooking, was applying polysporin on, got extremely itchy. This patient had multiple antibiotics, antivirals, intravenous antibiotic. I was also suspecting this. We actually did a patch test. Basically, I just told her to put a little bit of the polysporin on the wrist, had a clear kind of wheal and flare reaction, suggesting this is allergic. So, in the end, probably the amount of polysporin we're using is probably more good marketing. So, as you can see in this photo here, the child says, "I'm okay, mom. Let's just cover my boo-boo and keep it dry." And that's what you can recommend for your patients. Okay, guys, contact dermatitis, key takeaways. Very itchy. So when someone's coming in with any sort of wound, if they go, it's like really itchy, especially if that's the predominant symptom, think about some sort of allergic or contact dermatitis. If there's a diagnostic uncertainty, certainly if they don't have any like systemic, like hypotension, tachycardia, they don't feel ill. I just would hate for us to induce anaphylaxis, but for the most part, if it's just itch, ask them to put it on a separate part of the body and see if they get a reaction. And really, how we treat this is remove the nidus. Topical steroids is fine. Topical Benadryl, I think it's like $8 at a local drugstore. It is extremely effective for itch, so that's something else you can use. Okay, guys, case 3, bilateral cellulitis. Now, I hope when I said that word, as we've kind of previously discussed, where cellulitis, especially on the lower extremity, is unilateral, I hope some of you are making this face like this. Like, I don't believe you, Phil. What are you talking about? Because yes, bilateral cellulitis is extremely rare. This case says, but this time it's for real. So let's see if it is. This is a 4-year-old female with a history of intravenous drug use. Previously had a thrombus in their leg secondary to this. 2 weeks ago, they were or for 2 weeks now, they're complaining of bilateral leg pain, redness, swelling. They have a new job, they report, as a waiter, and they're on their feet a lot. They got 1 week of Keflix with no benefit. They note the legs are worse over the weeks. They're especially work in the evening after a long day of work. Their vital signs are stable. Their lung and heart exam is unremarkable. And her legs were swollen, red, and there was actually pitting edema in the lower extremities. The pulses on the dorsalis pedis and posterior tibial, so in the legs, the pulses were fine. In terms of labs, none. Nurses are not able to get blood work, and I think from our little Slido, this is not an uncommon issue with some of this patient population. So I apologize, this picture is a little bit blurry, but these legs were tender. There was pitting edema. They were both red and shiny, both of their legs. So, what would you recommend? Intravenous antibiotics because the oral antibiotics didn't work. Would you try to get blood cultures? The nursing was unsuccessful. Would you say, look, can we try again? Do you want to use compression on these legs? Do we want to give oral antibiotics? If someone could respond, again, this is completely anonymous. And I really encourage people to go for it because, if you do get a question, quote, wrong, you'll learn the most out of everyone here. You're in a way, you're a bit lucky. Like, okay, I got this wrong. I'm aware. Fantastic. Okay, guys. Maybe one or two more responses. Again, it's anonymous. I can't even see your responses if I tried. Okay, guys, fantastic. So this is a challenging case, right? We can't get blood work. There's pain in both legs. Now, I want to give some of the rationale. So bilateral quote cellulitis. So we discussed previously injecting the legs and history of DVT. Systemically feels great. And so why that matters a lot is the legs are so red. My rationale is how could it be that you feel so great? I note though, they're recently standing more. Morning, the legs are great. At the end of the day, they get bad. We started them on compression stockings and things improved very quickly. So this is actually an exacerbation of venous insufficiency. Um, I want to let people know. I want to let people know I've seen very experienced clinicians. I'm sure I have treated this with antibiotics in my training and over the years. So this can be tough to diagnose, and I want to go over how we pick it up. So in terms of the venous system, it's a reservoir to store blood, and it's a conduit for blood to be returned back to the heart. Majority of this is going to be stored in the deep veins. And so how this works is we have a set of valves in our venous system. We also have a set of pumps, and specifically the around the calf muscles, that pump is very important. And the normal venous ambulatory pressure in the superficial veins is 20 to 30 millimeters of mercury, which is why when we do give someone compression stockings, that is kind of the minimum requirement. So these calf muscles are super important. So that's why we want people walking because it will actually squeeze blood from the deep veins back into the intravenous IVC, back to the right side of the heart. Everything's good. The problem is when we have venous hypertension, we have obstruction of flow. Let's say someone had a previous clot there. If the veins get dilated, the valves stop working. If we're immobile, the pump in those calves stops working, and this leaves abnormal blood flow. So normally we have superficial veins take blood, put it to the deep veins, and then it returns. This abnormal flow means we have deep veins in the deep system going superficially. And that is what kind of leads to this inflammation and fibrosis. We have this hemosiderin, which is basically red blood cells that get digested. This causes inflammation, and that is part of the pathophysiology of venous insufficiency. And then that can lead to ulceration. So risk factors is advancing age, prolonged standing. So this is something we'd see maybe in someone who was a factory worker. I often see this in people who worked as bartenders, which although they're moving, they're largely standing stationary. It is associated also with high BMI, lower extremity trauma, previous DVT, and also family history. My tips, are people sleeping in a chair at night? If you ask this question, I promise you, you'll be so surprised about how many people are sleeping in a chair at night. And I do recall a patient that was referred to me with very impressive venous ulcers. Patient did have a history of ongoing fentanyl use. And the way we figured it out is we said, listen, next time you inject, get into a bed before you do it because they would inject, fall asleep, their legs would be hanging down for hours upon hours, and that would be exacerbating the fluid and the venous insufficiency. So ensure people are lying flat at night, which is basically make sure you get to their bed. And then also, if people have jobs where there's prolonged standing, it's very difficult to tell someone like, don't do your job, but trying to advise them that they could at least be moving is the best thing they can do. And then when they're sitting down, to elevate the legs. So I've touched on this compression. So compression stockings. Now, some of these can be expensive. In the meantime, if you find you see a lot of this in clinic, I don't work for any of these brands, but Tubigrip is a fantastic tool. You can give it to a patient. It's easy to put on. It's great for compression. Coban wraps are a little bit more formal. We need to have usually nurses are going to come wrap this every 2 to 3 days. Walking is good though, encouraging patients to walk. There is some evidence for an oral medication, pentoxifylline. I just want to mention this here so people know it exists, but to be honest, I don't have a lot of experience with it. I haven't seen too many leg ulcers or venous insufficiency. I have not been able to resolve without people getting their bed and compression. And then leg elevation. And what you need to tell patients is ankles above knees. So if they're sitting in a chair, those ankles ideally above knees or as best they can. Sleeping in a bed, and let's say you're seeing both legs are swollen, and you're thinking, I wonder if I should give this patient Lasix. What I would advise is that if this might be the situation to actually try ordering a BMP level. Now, I will say, if it's outside of a hospital, it's costly. So it really is only valid if you're affiliated with a hospital, but we don't give Lasix for venous insufficiency. And in fact, it could dehydrate patients. So just be aware that venous insufficiency can cause extensive swelling that will only resolve with compression. And I have a few examples here that I want to show you. So this was a patient referred to me. Patient does have a history of this was fentanyl, injects daily in the arms though, but sleeps in a chair. And if you look at their toenails, that they look a little green, and some people may think about Pseudomonas. These are certainly colonized, but this patient had gotten about 2 weeks of intravenous antibiotics. He reports there was no change. What we're seeing is actually some eczematous changes. So that patient actually might be a candidate for topical steroids, but the number one thing is elevating those legs and compression. This is the other leg as well. Someone else referred to me with on antibiotics. This is just venous insufficiency. There was no infection here. This patient had legs like this for weeks upon weeks. Also was not sleeping in a chair. Someone else, again, venous insufficiency, and this was an exacerbation. They had a hip surgery, so they've been a lot less mobile, but sitting in a chair with legs hanging down for some time. You get the idea. Another example, this person had oppressive bilateral pitting edema. These are the hemosiderin deposits, classic for venous insufficiency. Another patient, again, you're seeing legs are red, it's tracking up, you're scared. Blood work completely normal. This is also probably an eczematous reaction from inflammation from venous insufficiency. No antibiotics required. Now, you may be thinking like, but what if they get sick? You certainly should counsel the patients on if they get fever, if they feel sick, they got to present because they're at risk of cellulitis with the breaks in the skin, with some venous insufficiency and some breaks in their skin from their eczematous changes, but these are all venous insufficiency. Now, you're looking at this leg here. It's so red. I know you're tempted. This resolved without any antibiotics whatsoever. Again, they're at risk of cellulitis, but it's not there now. So some takeaways. Bilateral leg redness, certainly over weeks. Think about exacerbation of venous insufficiency. If you diagnose this, though, what changed? Are they less mobile? Are they standing more? Are they sleeping in a chair with legs hanging down? Tubigrip, potentially Coban wraps. Elevate the legs, though, when sitting, and sleeping in bed at nighttime is a huge step in the right direction. As I kind of mentioned earlier, that this was a meta-analysis done in 2023, and of all the studies, they show that misdiagnosis of cellulitis was 39%. Non-infectious mimics will be stasis dermatitis, that's the venous insufficiency, eczema, gout, trauma. Infectious mimics would be abscess. So basically, someone getting antibiotics when actually they have an abscess that needs to be drained. So I just wanted to highlight that here. So as a general rule, maybe 1/3 cases of presumed cellulitis have an alternative diagnosis. Consider mimics when there's bilateral involvement, chronic skin changes, and if you do think there's cellulitis and there's no change within 48, 72 hours, think if you have the right diagnosis, not just is this cellulitis, but is this maybe gout, or is there an abscess that needs to be drained? We are going to share these notes after, so I did put these prediction tools here. You can find them on MedCalc, and this is just, let's say you're a little unsure of treating cellulitis, you don't have a lot of experience. These are some good tools to kind of remind us of, is there asymmetry? If we have blood work, what's the heart rate? Also talking on the left one here about the acuity onset. Is this 3 days versus several weeks? Take-home points. As I said before, we're looking for anitis, acute onset. Are they sick? Are they ill? Thinking about IV antibiotics, and then assess for development of abscess. Phlegmon can turn an abscess that must be drained. And then if there's an abscess, think about MRSA and coverage. Okay, so we were talking about things we can see. Now we're going to shift gears and we're going to talk about screening for sexually transmitted and bloodborne infections. And so, trying to make this as high yield as possible. As I mentioned earlier in the start of this talk, all of these topics are huge topics on their own. So, I'm kind of giving you a little sprinkling of things I think are high yield. But certainly, if you have questions, I'd be happy to talk about anything in as much detail or as little detail as you want. Oh, this was the phone thing, making sure you have the phone call. So this is if patients, if you're going to check HIV, syphilis, Hep B, Hep C, making sure you have some contact, whether it's the patient, a family member, someone they trust, that you can call. And I often say, can I call the number in front of them? Because in my unfortunate experience, I find 50% the number they've provided doesn't work. So we're going to be delving into HIV, hepatitis B, hepatitis C, and syphilis. HIV RAM Clinic Essentials. So, this is the classic HIV, how it infects us. And what I want to highlight is it affects the CD4 count. And CD4 cells are our T helper cells. They help us fight infection. So this is why HIV is such a problem, is it directly attacks our immune system. And oftentimes when the demise of HIV is actually because people have opportunistic infections from long-standing HIV, the T cells are low, our body's able to get infected with other things. We have multiple targets. One of the newest drug available is the integrase inhibitors, and they drop the viral load very quickly, and they have minimal side effects. So we are in a great day and age for treating HIV because our treatments are fantastic with very, very minimal side effects. Um, and this is a classic, kind of anyone who Googles HIV will probably see this. Dr. Fauci was one of the authors on this paper. And this demonstrates that when we get acute infection, I want you to focus first on this viral load, which is the red. You see how it spikes up? That's what makes people very sick. So this is a viral illness that can look like any virus. It can look like mono, it can look like COVID. And this is why sometimes it gets missed, is because people come in with a viral illness. They say, I got some sores in the mouth, I feel sick, I feel icky. And then a week later, they say, I feel good, doctor. So then workup doesn't happen because they feel better until, and now I want you to look at the CD4 count, which is the blue, is that initially there's a drop in the CD4 count, but it takes sometimes up to 10 years to develop advanced HIV, formerly referred to as AIDS. And that's when the opportunistic infections develop. So meaning patients can have HIV for years and years and years, maybe with some symptoms or maybe without any symptoms that they don't notice. And this is why it's a very sneaky virus. We want to normalize HIV testing and addiction care. And oftentimes, if you don't do it yet in your clinic, I often would phrase it as you can ask people to opt out, but it's standard practice for whatever clinic that you test patients, not because you're stigmatizing, it's just part of your practice. And that's how I'd word it. 1 in 7 people in HIV with living, or one in seven people with HIV in Canada don't know their status. And in Ontario, about 11% of people living with HIV remain undiagnosed. So there's still a lot of work to be done. And so testing connects harm reduction with care. And so really trying to normalize that testing, making sure you have a contact for that patient. In terms of RAN clinic, we often see patients that inject drugs. They have overlapping sexual exposure, so high risky sexual behavior, and oftentimes have barriers to primary care. And so this is trying to normalize and get testing done when they are presenting and they haven't had a test in some time. Now, this is to scare you a little bit, but I'm going to break all this down. So these are our Ontario when to test HIV, and it is a bit overwhelming. I'm going to put this here as a reference, but this is how I would divide it. So when should you offer HIV testing? So think about infection first. So if they have an opportunistic infection, so shingles less than 55, they have thrush on the mouth, cytopenias, weight loss, even chronic diarrhea, swollen lymph nodes, all could be indicative of HIV. Um, so we talked about infection. This is kind of injection, infection, injection. It rhymes. So intravenous drug use, multiple sexual partners, even a history of an STI in the last year, 2 years, low threshold to check for HIV. And then key moments is also something to think about. We do check HIV when we're starting immunosuppressives. Everyone gets an HIV test when they at the first visit when they're pregnant. High risk people, we check them at the end of pregnancy, and even very high risk, we would check them at each trimester. Important to note is PrEP, which I will briefly talk about. I like to think of it as the birth control pill for HIV. We would be checking those patients every 3 months, but certainly we would check HIV before we start someone on pre-exposure prophylaxis. So infection, injection, active risk, and then important medical decisions is how one way of maybe memorizing when should we check people for HIV. Public Health Agency of Canada says that everyone from 18 to 70 gets at least one HIV test. So if your patient's never been tested, you can bring up this guideline that our public health agency says test everyone at least once. throughout their life, but ongoing exposures we should be testing regularly. When we do test a patient, we do use a fourth generation test. You may say, what does that mean to me? Well, we look at the antigen, and really this test is good because it will pick up HIV, new diagnosis, within 2 to 3 weeks of exposure. What that means is, let's say someone injected themselves with the virus, we would expect the test to turn positive within 2 to 3 weeks. How can you make this practical? Is if someone had a high risk exposure, whether it's a sexual or injection drug use, and your test is negative after 1 week, you would want to make sure you have a way to test them after 2 or 3 more weeks because there's still a chance that they're in the window period where their test was negative, but they do have HIV. Now, talking about HIV diagnosis, and I'm not sure what area of if people have had this situation come up, but it's important to let patients know that we can give them hope that now, with the drugs we have, there is no reason why they cannot live a normal, healthy life. And essentially, with starting treatment quickly, that patients will often live as long as someone without HIV. And so it's very important to know that this will, and what I tell patients is that soon your HIV diagnosis will be a very boring part of your life. Well, we have to get some blood work. We got to make sure everything's in the right direction. And that's what it ends up being. Oftentimes, we have patients living with HIV. We see them once a year. We don't even talk about their HIV. It's more of, hey, how are you doing? And I often describe the scenario as that's where I expect my future patients to be. We want to engage in shared decision making. And then although we know we want to start patients off this medication as soon as possible, we want to make sure that there's a readiness to start. And if they have any questions that they're going to get through this and everything's going to be okay, some patients may say, listen, I need a day before I start this right away. And part of this shared decision making is also, I think, of the background of where are they going to get the drug coverage, which there's always answers to that, where they're going to pick their drugs up, how can they tell partners? So there is a lot of things to be discussed, but I think hope would be the number one that they're going to be fine. And then offering treatment early. Ideally, you want to offer treatment within the first week of diagnosis. And Biktarvy, I would say, is the drug that we would typically use. Again, I have no affiliations. There is other first-line medications, but one involves checking for an HLA test. The other one does involve a viral load that's less than a certain amount. So I think Biktarvy is kind of the safest that you can start that in anyone while they're getting further workup and while they're waiting to see their specialist. Starting early, we want to support adherence, the importance of taking that pill every single day. And we know if patients take that, we say HIV is undetectable, which N equals untransmissible. And so what this is that someone who is HIV positive or living with HIV, who has a partner that doesn't have HIV, if that person has viral load that's undetectable over 6 months' time, so viral load's undetectable 3 months after treatment, it's again undetectable another 3 months down, and they're adherent to the medication, the risk of them transmitting HIV to their partner is essentially negligible. And I think this is an important message to start off early on. So, again, a lot of variation in where you may practice, but I do want to walk you through this. Won't take long, but someone gets a new diagnosis. What do we typically do? So we check for a viral load. Now, this doesn't actually happen with their first HIV test. You do have to order this separately. If you order this test, though, public health will automatically do a genotype test to look for any resistance. That being said, Biktarvy, it is extremely rare that antiviral would not work. So baseline genotype, that would be a problem, is very unlikely. Then we check their immune status. And so we look at something called CD4 count. That's another test we would order. In here, I also we check a CBC and a complete metabolic panel, which consists of liver enzymes, glucose, creatinine, electrolytes, as sometimes those can be affected by the medication. Notice though I put this little alarm around the CD4 count less than being 200. If you do have a patient that has a CD4 count less than 200, oftentimes we do actually put them on a prophylactic antibiotic. And I think I would leave this as if you do a CD4 count on your patient and it's less than 200, I do think that would warrant a phone call to an HIV specialist just to discuss what to do from there and ensure the patient could be seen quickly because there could be further complications that could be quite severe associated with that. We do check for co-infections. So I think a reasonable thing would be is checking HIV, hepatitis A, B, and C. We check syphilis, gonorrhea, and chlamydia, which would be site-specific. So if they engage in receptive anal sex, we would do a swab there. We do a tuberculosis skin test. Toxoplasma, CMV, cryptococcus, a bit more obscure. Happy to answer more questions about that, but I just want to list that here for completeness. And then we would do vaccinations. There's a variety of vaccines we get. If you're just making the diagnosis and the referral, I don't think you're in a rush to give any of these vaccines. This is just for your information for completeness that there's a lot of vaccines that we give them. I left out meningococcal here as well. So PrEP, this is pre-exposure prophylaxis. What I want you to all be aware of is that if your patient has high risk sexual activity or is sharing needles of people that could have HIV, the question you want to ask yourself is should they be on pre-exposure prophylaxis? So, who is eligible for this? So, condomless sex with partners of unknown HIV status, anyone with multiple partners, and there is a bit more focus on men that have sex with men and transgender females just because they are classically higher risk. Recurrent sexually transmitted infections, and if they have an HIV partner, if not confirmed undetectable, and then also people that are sharing drug equipment with a history of intravenous drug use could be candidates. So before we prescribe it, we get baseline labs. Importantly, HIV. We want to make sure they're HIV negative because the medication we give is part of an HIV regimen. So we don't want to be partially treating the virus. We also get Hep B and C and syphilis and chlamydia gonorrhea, it's site specific. First line medication is Truvada, which is a component of HIV medication, and then coverage. There is multiple ways to get coverage. Prep Start in Ontario is a 1 month of free. Multiple clinics will give 3 months free. So often some patients can go to clinic getting 3 months supply, but there's also multiple ways to get coverage. And also be aware of once patients on this, they will be seeing a provider every 3 months to get repeat HIV testing, checking renal function, and also doing STI screening, syphilis, gonorrhea, chlamydia as needed. Doxypep, again, I just want to mention this, is that this is also given to MSM and trans women with bacterial STIs, even just one in the last 12 months. Basically, they take a pill 72 hours after condomless sex, max one-time dose per day, and this has been shown to decrease STIs, including syphilis, chlamydia, and even gonorrhea by 53% in multiple studies. So it helps prevent STIs. Of note, sometimes patients come asking for doxy post-exposure prophylaxis, and they're not on pre-exposure prophylaxis. And I often say that that doesn't really make a lot of sense because really the most important untreatable or uncurable would be HIV. So if they're going to be on doxypep, they really should be on pre-exposure prophylaxis with Truvada. Okay, hepatitis B. Hope we're not going too fast. Again, happy to take more questions. So hepatitis B. So 250,000 Canadians live with chronic hepatitis B, and 40% are undiagnosed. And it's actually 50 to 100% more infectious than HIV. What that means is if you were to take a large bore IV and it was filled with blood of someone with HIV, and then another one is filled up with hepatitis B, there's about a 0.3% chance of getting infected with the HIV needle versus about a 30% chance of getting infected with the hepatitis B. The one comforting thing, though, is that as an adult, if you got infected with hepatitis B and you were non-immune, there's about a 5% to 10% chance of you developing chronic hepatitis. As an adult, many people will clear this. It's more that the infants, when they get it through the birth canal, it's very infectious. About 90% of the time, if they get chronic hepatitis B, they'll have a lifelong infection. There's a 25% lifetime risk of cirrhosis or liver cancer if untreated. And what's very significant is unlike hepatitis C or alcohol use that goes from cirrhosis to then hepatocellular carcinoma, hepatitis B can cause liver cancer, hepatocellular carcinoma, without going through cirrhosis. So that is why it's so important that patients with chronic hepatitis B get monitored. So most chronic infections are due to birth exposure early in life. We see this much more commonly in people that were born outside of Canada, so endemic regions like Asia, Southeast Asia, and Africa. And usually people will get screened before they come to Canada, but sometimes they could be lost to follow-up and that just kind of never got discussed. So in Canada, our guidelines actually recommends universal one-time screening for adults over 18 years of age. So everyone, one-time screening. This will consist of a triple panel. This is hepatitis B surface antigen, hepatitis B surface antibody, and hepatitis B core antibody. Notice I highlighted the surface B antigen. If someone has hepatitis B surface antigen positive, they have Hep B, that warrants a referral. Now, if patients are not vaccinated and there's ongoing risk, we certainly would consider retesting them. But if they're not immune, we do recommend vaccinating. And pretty much everyone is a candidate for vaccine. So this is if the antibody for the surface antibody is less than 10 international units per liter, and obviously they don't have active hepatitis B, we want to vaccinate those individuals. So a few scenarios here. Patient has hepatitis B surface antigen, referral, they have chronic hepatitis B. Patient has only hepatitis B surface antibody. They're immune. They require no further testing. They're at no risk of getting hepatitis B, even if they have high risk activity. Okay, so if they're immune, they're fine. Don't need to recheck it again. Isolated core antibody, this is a bit of a trickier situation. It implies they've had previous infection, they've generally resolved it, but we generally recommend those patients get checked for HBV DNA. And oftentimes, it's not a bad idea to make a referral just for a discussion because if that patient were to get immunosuppression, that could cause reactivation. And then finally, if everything's negative, no antibodies positive, they're susceptible, so we want to vaccinate that patient, especially higher risk. Some people may argue, well, what if we can't know if they're going to come back for follow-up? I would still try to give them one vaccine, and then if you see them in a year's time, give them another vaccine. In the long run, we can hope that they might be immune. So, vaccine in Ontario, pretty much all non-immune adults are eligible. High-risk patients being patients with intravenous drug use, MSM, HIV, hepatitis C, household contacts of hepatitis B, and healthcare workers. So our schedule is typically 0, 1, 6 months, and then we check titers 1 to 2 months after the final dose to look for immunity. So referral and follow-up. So if someone does have hepatitis B surface antigen positives, they have hepatitis B, we want to make a referral. They will need, and you can order this if you feel comfortable, hepatitis B DNA, E and antigen and anti-E hepatitis B E antibody, liver enzymes. And if you do have access to a FibroScan, otherwise a CBC would be helpful because we actually calculate something called the FIB4. Simply put, it's a test that can kind of help us estimate if the patient is risk of cirrhosis, which would further excite us to treat their hepatitis B. We check for co-infections with HIV, Hep C, and now guidelines say checking for hepatitis D, which actually before were thought to be undiagnosed and can progress the risk of cirrhosis with hepatitis B. And if someone does have certain risk factors, so they're from certain countries where hepatocellular carcinoma is more endemic, we actually will screen people for ultrasound every 6 months, even if they don't have cirrhosis. This is for certain high-risk individuals. And we do vaccinate household members and sexual contacts. Okay, guys, two more, hepatitis C and syphilis. You've done good. You've done great so far. We're good on time. Hepatitis C. So the big thing with hepatitis C is it has no symptoms. There's 110,000 Ontarians living with hepatitis C, and 44% are unaware of their infection, and 67% never got tested. RAAM patients often have overlapping risks, so intravenous drug use, non-sterile tattoos, and unstable housing. And most people, as I said, have no symptoms. So it's very rare where someone will have symptoms of hepatitis C, unless, unfortunately, it's advanced to cirrhosis. So, universal screening. So, people from regions where hepatitis C is endemic, and then anyone with a risk factor, and I'll go over that. But I just want you to be aware in the US, they actually recommend like universal screening for everyone. And for us, we don't quite feel we have the evidence in Canada to screen everyone, but there are so many reasons to screen. And I would say if you're seeing someone in a RAM clinic, that alone should be justification to order a hepatitis C screen in the right context. So we do also evaluate it with looking for liver enzymes. Could be a cause of hepatitis C. So if someone had liver enzymes, we would check hepatitis C. If they have other symptoms of liver disease, swollen belly, certain rashes can be associated with hepatitis C, kidney disease. If someone has HIV or Hep B, we would have to check hepatitis C. People who inject drugs, share equipment, or non-sterile tattoos or piercings. So this is kind of from our Public Health Agency of Canada. That we have many reasons to test people. Blood transfusion for 1992, exposed to blood during sexual activity, sharing personal equipment with someone with hepatitis C. There's a lot of reasons, so low threshold for check for it. Now, some people get a little confused on this. If someone has hepatitis C antibody, that doesn't tell you they have active Hep C infection. Finally, though, Public Health Lab will reflexively check RNA. RNA positive hepatitis C antibody means they have hepatitis C and they're a candidate for treatment. So, hepatitis C RNA means current infection. If the RNA is negative, it means they resolve the infection. And just to kind of reiterate, antibody test is a screening test and RNA is diagnostic. And why this matters is that about 25% of patients that get infected with hepatitis C will spontaneously clear it. So many people have Hep C antibody positive will actually resolve the infection on their own without any treatment. We have great medication for hepatitis C, greater than 95% cure with direct acting antivirals. Patients will get treatment of 8 to 12 weeks. They take the pills often with food, minimal side effects, and it is extremely efficient. So we really want to treat patients as soon as we can. Patients on methadone or Suboxone can actually pick up their hepatitis C meds with opioid agonist therapy, and this actually has been shown to dramatically improve adherence. Active substance abuse is not a contraindication for hepatitis C treatment. So just be aware of that many patients are getting treated in situations even with unstable housing. Positive test, treat, and then minimal on-treatment monitoring. This basically refers to, we used to think patients with hepatitis C need to have blood work after 4 weeks' time, but now this has been studied well. We can treat them, send them on their way, maybe follow up with a phone call to ensure adherence, maybe discuss having their medication dispensed when they're getting their opioid agonist therapy. Um, with the caveat that if someone has co-infection with hepatitis B, HIV, there are a few other scenarios. And so if you are considering treating this and you haven't done it before, I certainly would want to, even if it's a consult over the phone or through OTN, electronic consult, having a specialist kind of weigh in and make sure there's nothing you're missing. And then in terms of testing, we want to do this in frontline clinics. So this is done in prep clinics, RAM clinics, shelters, ED. And so RAM clinics can play a critical role in testing for this. And people ask, how often should you test? So depending on what the risk factors, I would say is if you're seeing them every 6 months, because that's only when they come in, I would test it then. Most guidelines would say you do it once a year. If someone has hepatitis C antibody positive but RNA negative, you probably would repeat an RNA test once a year rather than every time you see them. Because the good news with hepatitis C is it is a slow virus. It's not going to progress to cirrhosis. Very, very rarely will it progress to cirrhosis very quickly. Okay, guys, last one, syphilis. We're doing great on time. So often missed, also could be asymptomatic, but it's easy to treat. So why does it matter? What are we going to look for and how to test and then what to do next? So syphilis rates are rising. It's a sexually transmitted infection. 44% of people in Ontario are unaware. We actually, unfortunately, have rising of congenital syphilis, something that we thought was like almost non-existent. And RAM patients have higher exposure, not just from PWID, but unstable housing, probably more likely to be involved in chemsex and multiple partners. Bottom line, you will see this. So what does syphilis looks like? I do have some pictures, so if you're eating dinner, this may be a time to put down the sandwich. So primary syphilis, it's a painless ulcer, and this often goes unnoticed. It actually is a bit of a miniature vasculitis, and so it affects the neurovascular bundle. So it's unlikely that patient will actually have pain from these sores. Not only that, but if this is inside a vagina, if this is inside someone's rectum, someone who's participating in sexual activity with those people won't often see this, so it can get unnoticed. Secondary syphilis can consist of a rash, and classically it's on the palms of the hands and soles of the feet, but it can be anywhere. It could also cause mucus patches and something called condyloma lata, which can kind of look like genital warts. Latent syphilis, by that definition, there's no symptoms, which is very common. Red flags to be aware of, and this can happen at any stage: meningitis, stroke, uveitis, hearing loss. That would be a situation where you want to refer someone urgently to emergency room or a specialist because that will involve them being on IV penicillin for a minimum of 2 weeks. Syphilis is also known as the great imitator. So if you're seeing something strange, don't know what it is, low threshold to check for it, especially if you're getting blood work for anything else. So this would be an example of a chancre. So again, this is typically painless. This is one on the cervix, penis as well, other spots here. You're probably thinking this looks like HSV, this looks like cold sores, and you'd be 100% correct. You would be definitely right on track if you were to swab this for HSV. But if you don't think you're going to see that patient again, I would treat them for syphilis. I would also give them antivirals for HSV. This is on the rectum there. Again, both of these can look very similar. The classic appearance of syphilis, though, is a heaped up border. It almost looks like a button you would see on a shirt like I'm wearing. That also might be a tip off. Typically, it's painless, but HSV can be painless. I've seen syphilis be painful as well. Other thing I want to mention here is that if someone were to have an infection around the rectum and it's distal to something called the dentate line, it actually drains the superficial inguinal lymph nodes. What does that mean? Someone can come in with right groin pain, and this is actually from a syphilitic chancre on the rectum. So if you don't check that area, you won't find it. The rash in secondary syphilis is usually maculopapular, can look more copper-like in patients with darker skin. And although, again, the classic reading is palms and soles, palms of the palms and soles, it can be a rash anywhere, so just be aware of that. Oftentimes, patients will come in when I see them that they saw a dermatologist and told it was laundry detergent, but they've been using the same detergent for a long time, so just to think about it. This would be the classic rash on the palms of the hands, soles of the feet, palms of the hands. Again, these are the mucus patches. on the left here, and then they can get alopecia, which often can be described as moth-bitten or moth-eaten. So it looks like someone took a chunk out of their hair. Not uncommonly, patients can be referred to a dermatologist who often will astutely pick up that this is actually secondary to secondary syphilis. So, who to test? New partners or multiple partners, patients that have condomless sex, MSM, sexual activity, recurrent STIs, low threshold for PWID, sharing equipment, HIV, Hep C, and honestly, if someone asks, test them. How does the algorithm work? Now, this can often lead to a lot of confusion. I'm going to do my best, and I hope we can understand it. So, we start off with what's called a treponema test. So, this is an EIA or CMIA test. This is a screening test. And this is relatively specific, although it can pick up other things. So, if this test is negative, it's done. We move on. However, if a patient is Shanker and you are highly suspicious, only about 70% of these tests will be positive. If it's positive, the lab will reflexively do something called an RPR, which is considered a non-specific test. The RPR titer, the non-treponemal, helps you stage and monitor treatment. So we look for, if someone's had syphilis before, we look for a four-fold rise or a four-fold drop for adequate treatment. And then important that the treponemal test will stay positive for life, so we do not use this to follow treatment. And I'll show you some examples. So if someone's EIA is positive, the RPR is positive, and there is one more confirmatory test I'll talk about, we treat with and then 2 shots to the buttocks with benzoyl penicillin. If we don't know how long someone's been positive for, so it's the first time test, they've never been tested for syphilis, we treat it as something called late latent, which includes weekly shots to the buttocks, these 2 shots for 3 weeks. On alternative, if you have no access, you can't get the patient to come to clinic, instead of that 1 shot, we would do 2 weeks of doxycycline. And if we have unknown duration, we would do 28 days of doxycycline, 100 milligrams twice a day. Neuro symptoms, vision, hearing issues, if they're pregnant or a very high RPR, I would say over 500, that should require an urgent referral. And then follow up for the primary syphilis, we actually repeat RPR level at 3, 6, 12 months to ensure things are climbing down, and public health will do contact tracing. So this patient, high risk sexual activity, as you can see, their EIA is negative, no further testing to be done. Public health would say negative, negative, negative. We're happy with this. Now you look at here, this patient, so this was done many years ago. You can see that they were many, many years ago, before January, this is US, January 22nd, 2016, they previously had syphilis, were treated. The RPR went down to non-reactive. They had a new syphilis infection. The EIA stays positive, as we know. The RPR now is newly positive with a new titer 1-256. So this is a new infection, and this patient was treated with 2 shots to the buttocks for primary syphilis. This here is something called serofast. So the syphilis screen's positive, the RPR titer stays positive, the titer fluctuates 1 to 8, 1 to 4, 1 to 8, 1 to 4. This is not uncommon for people that have had syphilis many years ago before it was treated. And oftentimes this will persist throughout their whole life. So you may ask, well, how do I know if they get a new infection? Is that we would see this 1 to 4 will go to like 1 to 32. And then we'd often have some sort of clinical story. So treponemal test says yes or no if you've had syphilis, and the RPR refers to how active it is and if the treatment worked. So syphilis, again, is a great imitator. It can affect pretty much any organ, and that's been showed, it's been documented. Many patients don't recall a primary lesion, so symptoms vary a lot. Test whenever you're unsure. Okay, guys, so my takeaways. Don't overcall cellulitis, consider mimics, especially if it's a chronic presentation. If there's an abscess, first thing is we want to drain it, and that will cure a majority of patients. Screen broadly with HIV, syphilis, and Hep B, C, especially if you're getting blood work for one thing. Is there an HIV risk that's ongoing? Are they a PrEP candidate? Multiple clinics will help put patients on pre-exposure prophylaxis, assuming they have an HIV test negative first. And then hepatitis C, RNA positive means we can cure and treat them. So those would be candidates for treatment. And then also the RAAM clinic, it's an entry port for ID care. Okay, that is what I have to say. And now I will take all and every question.
Wow, is all I can say. That was like a bit of a race. So much fantastic information. I have some questions. I've been keeping an eye on the chat. Please
Okay.
keep adding them.
Yep.
Um, I want to ask something practical
Yep.
around testing in
Yep.
terms of filling out a standard lab rec, like
Yep.
an bolus rec. and a public health rec.
Yep.
So you've inspired everybody. I'm going to
Good.
say that, let's say we want to, we want to test for everything.
Yeah.
What do we need an extra requisition for? What's
Yeah.
going to be done reflexively?
Yeah, yeah. So the HIV will often need a separate test because they actually have some questions they ask, which is like
Yeah.
the Caucasian reason to testing. And, you know, don't stress too much about that because some people are like, I don't know why I'm testing. Honestly, it's not that important. It's really that it gets done. But for your syphilis test, I'm sorry, and on your general public health rec, there is also a checkbox for Hep B, C. Those ones are easy. Syphilis, you can write on that, the general public health. It's the
But can you
HIV.
write VD? You don't write VDRL anymore. You now write
You
your
can just write
DDL.
syphilis. You can just write syphilis.
Write syphilis.
Yeah. And so
Okay.
keep it, that's a great question, actually. Keep it simple for syphilis because if you were to write like EIA or syphilis, you might confuse someone there and they won't do it. Syphilis is easy.
Okay.
You bring up a really good question. We're trying to make this as easy as we can. So I would say is it either a Public Health Ontario, a general lab rec. If you're unsure, put on the public health one specifically, that's the one you need the specific HIV. And then on the general one, just write all the tests that you want so it's very clear. Like I write it twice if there's any doubt if you're worried someone's going to get rejected. I'm just,
So,
yep,
okay.
yep,
So we've got the general rec, so we could do like a urine or whatever we want for GC chlamydia. We
yep,
ask for syphilis, hepatitis, ABC.
yep.
To see, you're saying if it's positive, the lab will reflexively do RNA?
Yes, and this is something that's new. So I don't remember exactly when they introduced, but a few years ago, you had to separately order the RNA. And you can imagine people like me would pull our hair out because the patient's gone. We what do we do now? So, but if now, because it reflexively does it, if it's negative, okay, we don't need to make a call. The patient's cleared it. You know, we would like to say, hey, you have this test, you cleared it, but if you can't contact them, that's fine. The only situation that's a little more tricky is if a patient has known hepatitis C in the
Mhm.
past, meaning hepatitis C antibody positive. Their RNA was done previously and it was negative. You want to recheck the RNA test, let's say because they have ongoing exposures, you will have to specifically ask for Hep C RNA.
And if they have been treated and
Yep.
cleared, and you
Yep.
want to continue to screen them because of ongoing risk, you're going to need to order an
Hep
RNA.
C RNA, exactly.
Okay.
Yeah.
And if you're ordering an HIV test, is
Yep.
there, again, before, let's say we're not treating and monitoring CD4 counts and viral loads,
Yep.
HIV P24 is what we're ordering?
Yeah. In fact, you don't even have to think about that P24. All you need to think about is look at this test here. Can you see my screen?
Yeah.
Okay, yeah. You see how it says HIV serology? Boom.
Yeah.
That's all you're doing. Nothing further.
Okay.
Yeah.
Get
No
PCR, forget anything else.
Exactly. No one should be expected to know what a fourth gen, like I mentioned here, just because I'm an ID doctor, but really, I do not expect anyone outside my specialty to know anything further than HIV tests. Those words.
Okay.
Yeah.
So,
Serology. Yeah. HIV serology.
okay, thank you. So
Yep.
to clarify, there's a
Yes.
comment in the chat.
Yep.
Public health will only reflexively do the Hep C RNA if it's the first Hep C antibody
Yes.
positive result. So that's great to know. So any
Yep.
follow-up you need to order specifically. It seems as though some people have been lucky enough to get these tests done without using a public health rec, only the regular MOH. I don't know if that has to do with which lab you're using. But I guess if
Oh,
theoretically we should have the regular OLS, the public health HIV, and the public health Hep C, and I guess, and Hep B is on the same one as the Hep C, right?
yeah. Yeah. All the hepatitis. I'm just going to pull it up
Yeah.
here. The problem
Okay.
is also for me is working in hospitals too much, where unfortunately, sadly, I don't fill out some of these requisitions so much myself. Let's see here. Yeah, so this would be the general test work. General check. These are these check boxes here, right? Boom, boom, boom. But for the Hep C, you would want to write in Hep C RNA. The good
Yeah.
news is, if you didn't do that, if it ends up in public health, they keep that blood for like 60 days. So if you forgot to
Hmm.
order it, you probably can most certainly, I just haven't done this in a year, so I don't want to, but most certainly you call them and say, hey, I wanted RNA test on that. It wasn't a mistake. Please do it. In a perfect
Hmm.
world, they would look through the chart and be like, oh, the patient hasn't had RNA testing. The doctor ordered it. They do it. Not
Hmm.
always.
Okay.
Good. Great questions, guys.
Yeah, no, and I see these more questions, different recs. People are, yeah, it is challenging. I've sort of, my strategy is put them all on a desktop.
Yeah.
But yeah, the idea of having them ready to go. And
Yeah.
obviously, we're not talking tonight about point of care testing, but I know that
Yeah.
that's a whole
You know,
other,
again, and then 100% point of care, if you have act, is fantastic. The
yeah,
HIV one, the Hep C, we're doing more and more of that. I apologize, I didn't go into that. I was actually, I thought long and hard about it, and so I will answer questions or specific ones on that. But the one thing I also mentioned is that if you find you're trying to increase your testing, and let's say you're unsure, sometimes I'd say maybe call public health,
mhm,
clarify exactly what they need, do it one time, say, okay, I'm going to take 20 minutes, and then have your recs ready to go. When you want to screen, you pull your recs, you've clicked off the boxes already, you put the
mhm.
patient sticker on, it's good to go. So wherever your practice is, make it an easier process for you that you don't have to think each time, what do I
Yeah.
do for that? That you've pre-filled it out as best you can.
That's a great, great point. Okay, I know, Lori, I'm going to pose one other question, and then I think you said someone wanted to unmute to ask a question. Before that, a question about hepatitis B,
Yep,
then the verbal question, then I want to go back to some of the edema and cellulitis.
yep.
This is a two-parter.
Okay.
Once someone is shown to be hepatitis B surface antibody positive, so let's say I'm assuming this is a question about immunization. Their level then drops below 10. Do they need a booster? And actually, the other part of that question is, do we like why do we bother to test
Yeah,
for
great
antibody
question.
levels at all?
They're probably immune. However, this is one of those kind of areas that's a little iffy. I would want to know how much it drops. For example, let's say they're 10, which is the cutoff, and they go to 9.
Mhm.
This is how I would approach it. I'd want to know what the risk is. So let's say I think they're very high risk, like high risk sexual activity, sharing drug equipment. I would probably say, do I give them one extra dose of vaccine, or do I just recheck it in a few months' time and let it come up on its own? Let's say you're not sure if they're very high risk, and you're not going to have access to them again. Maybe give them one booster, which is just one dose of Hep B, and I wouldn't really feel rushed to check it again, assuming that they were born. It's in 1987 and after where we routinely started introducing Hep B vaccine in grade 7. So they were probably vaccinated. So that's what I would do in that situation. And if you're ever uncertain, I'm also an OTN. You can always send me a patient. I'll review it and tell you what to do.
Fantastic. Okay,
Yep.
the second Hep B question, and then we're going to
Yep.
move. If someone is so Hep B core antibody positive,
Yep.
Hep B surface antibody positive as
Yep.
well. Is this a resolved infection? Do
Yep.
we need to do
Great.
any DNA?
This is a resolved infection, and those people, even if we were to immunosuppress them, they're at even less risk of any problem. So I would say resolved infection, nothing to do.
Fantastic. Thank
Yeah.
you.
No worries.
Okay, Lori, did you want to
Good
unmute? I
questions.
think Sonia had a question. Please go for it. You can unmute yourself, Sonia, I think.
Yeah. Sonia. Yeah, there you go.
Okay.
Hi, you can hear me?
Yeah.
Yes. Hi, hi,
Okay.
welcome.
Hi, thank you so much. This was phenomenal.
Oh, my pleasure.
So much in a short period of time and
I
just
know.
really high yield. So just a couple of things. I'm also an ER physician. I'm seeing some. I work in rural communities, but my base area is in a suburban hospital. So there is good follow up, good home care, and all that sort of stuff. A couple of things. Is it still so if someone's not constitutionally unwell, but you feel that they truly have sort of a large area of redness that's new, it's a cellulitis, is first of all, oral antibiotics at the appropriate dose, like Keflex 1 gram QID, equally as bioavailable to avoid an IV therapy. And secondary, what's the I see in some departments that somebody gets an IV ceftriaxone for cellulitis, and then their IV gets taken out because they're a drug user, or now they're doing IM. I'm just wondering, realistically, what's the risk benefit of having maintaining a patent IV if we really truly think that they need IV therapy,
Yeah.
versus them then injecting another site to use their
Yeah.
drug? I'm
Yeah,
just,
and great
what's the
question. Yeah, thank you so much. That's a fantastic question. And this has been studied. And to be honest, I myself have no issues giving people IV antibiotics, even a PIC line, even with active substance abuse. But I have a conversation. I say, look, we're giving this line. This goes close to your heart, or goes directly into your vein. You can't use it. And I think I can count the time of the like hundreds of patients where we've had intravenous lines in them. I honestly can't think of anyone, or maybe one patient who even probably told us, like, don't give me an IV site. I'm going to use it. So I'm okay having that conversation. And then also to ask your question, if someone has bad cellulitis and they're, systemically, like they can eat, they can drink, I'm okay giving oral antibiotics. And if you were to give Keflex at 500 QID or 1 gram TID, probably a little better for adherence, I'm okay with that. It has good bioavailability. The situations I'd be a little hesitant. If we're dealing with weight, BMI, or kilograms of over 120 kilograms, we have to adjust the dose. So that's when we give like a Keflex 1 gram TID. And if it's spreading up the whole leg, I probably would have a lower threshold to give IV cefazolin. The other thing I would say is I can't stress the importance if someone does have cellulitis of elevating their leg. If they're able to compress it, that will speed up the process. If someone has diabetes, and specifically if the sugars are much higher, those are patients I often will want to put on IV therapy before I switch them to pills, even though it is largely you got to control the sugars. But when I see diabetics, I get nervous because things can get bad very quickly. So often I'll start them on IV, maybe even just 3, 5 days, making sure things are getting better before I switch them to oral therapy. So did I answer your question? I spoke a lot there, but you want to clarify that?
Yeah, that's absolutely that's exactly what I wanted to know. So thank you so much.
Okay, good, good, good.
Okay, a few more cellulitis and edema related questions. One, do you use cefadroxil for BID dosing? That was
Great
my
point.
question.
Cefadroxil is a great drug because it's only twice a day. But only caveat is that make sure your pharmacy has it. So that's the reason I didn't mention it here, although I do love it. I often I know what pharmacies carry it before I prescribe it because worst case, you give someone a script, they go all the way there, they got their script ready, and they say, yeah, it'll take us 2 days or 5 days to get Cefadroxil. I don't have it. Then you get a phone call and you're just like, you're not working. So great drug, Cefadroxil, 1 gram PO BID twice a day, as opposed to Keflex. Great drug. Make sure the pharmacy has it.
Thanks. Um, Duration of antibiotic therapy, like shortened up a lot, right, for
Yeah. Yeah.
uncomplicated cystitis and chest infections.
Yes.
So can you just review when we should be thinking about 5, 7,
Yeah.
10? Is
Yeah.
there even a role
Yeah.
for longer than that in terms of
Great. Great.
a true cellulitis, right?
Yeah.
Not
I would say this is if you're considering treatment more than 7 days, you really need to be asking yourself, is there an abscess here? Is there an alternative diagnosis like gout,
Mhm.
like a DVT? You really want to ask yourself. And so I would say if you're thinking about extending it over 7 days, might not be a bad idea to get an opinion.
I guess
Infectious.
I can think of situations where people are um, I think their circulation is really compromised, right? Where we're
Yeah.
seeing infections in a forearm, it's complicated by
Yeah. Yeah.
repeat injection, improving, but really not resolved. I take your point. The erythema doesn't have to be all gone, but they need to
Yeah.
really look like they're getting better.
And I guess what I would say is it's difficult because here's the thing is if someone has gout, okay, I'm just going to give a dramatic example. They will get better with antibiotics. Why? Because gout will get better without antibiotics. And so will many wounds. So although the wound's scary, you kind of want to ask yourself, like, are the antibiotics definitely helping? Is it coincidental? But I want us to focus on wound care. That being said, I want to give one scenario which changes things a little bit. If you have a patient that has a history of MRSA or even Staph aureus, MSSA, or any bacteremia, you want to overtreat that? I am very, very okay with that because that is a life-threatening condition. So if you want to say, look, I'm nervous, I want to give 3 weeks, 4 weeks, I'm gonna have a hard time telling you no because they had a
Mhm.
life-threatening condition that kills people. So,
Mhm.
but if someone's never had
Daddy
bacteremia,
took it, never returned it.
what'd you say?
Oh, I think you need to just mute yourself again.
Oh,
I'm sorry.
sorry. Yeah, okay. So I was saying, yeah, if someone's been bacteremic, I'm okay treating a little bit further because that would be the patient's very high risk. If they've never been bacteremic, I'm okay saying, you know what, let's try stopping antibiotics for a little bit, but let's focus on the wound care. Are you changing your dressings regularly? And wound care 101, if you're changing the dressing every 3 days and when they change it, it's disgusting of pus, change it more frequently. They change it once a day, it's full of pus, change it twice a day. We really want to keep that area dry. That will help with healing.
Yeah, I have lots of questions and challenges thinking about wound care. We might have to have you back. Are Dopplers unnecessary? Anything when it comes to making this diagnosis and coming up with, a plan for compression? Because I just see that as an almost insurmountable barrier for many
Yeah.
patients.
I would say, and I want to clarify, you're talking about getting a Doppler to document that they have no peripheral vascular disease to get compression. Is that what we're getting at, or something
Yeah.
else? Yeah, I
With
would
like
say
they
is, yeah, I would say is documenting the patient has strong pulses. Like if someone's a young person, we have no reason for them to have vascular disease. They should be on compression. What I tell people though is even patients that have end stage peripheral vascular disease, very advanced, I still give them tubing grip. I feel it's fantastic. If we're in a situation where we want to do something like Coban wraps, I can understand the concerns from, let's say, the nurses in the community because they don't want to wrap wounds up and no one looks at them for 2 days. So in
Mhm.
those situations, trying to, even if you have a peripheral Doppler, which is really easy to do yourself, or just feeling for pulses, I could understand why they want that. So it's a case by case. But again, to be grip, you can I honestly it's like $60. I keep a bunch in my clinic. It's my favorite thing I have as an ID doctor.
Wow.
Yeah.
Okay. I
And the
want to get
roll,
that.
by the way, a $60 roll, that's like so much to be grip. You won't ever so you just I cut some off, I give it to a patient. So if you're seeing patients with chronic wounds, invest in some tuba grip. It's cheap. It's so easy to apply. You cut, patient loses it, you give them another one, dirt cheap.
Okay, takeaway. Okay, another question about swelling from Katie, who says, I commonly see patients using stimulants present with peripheral edema. Is there any particular reason for this? Is it more time on their feet? Is there something about the stimulants more specifically?
Yeah, good question.
And anything that we would lead you to recommend a different kind of treatment
Yeah.
approach?
And I've looked this up quite extensively myself. I have not found any sort of substance associated with that. But from my experience, which is a lot of this, it's injecting, falling asleep with their legs hanging down. And so it's venous insufficiency that we're seeing in young people. So what I would tell people is like, listen, let's say they're injecting opioids, is, if we can get you in your bed, obviously there's so many other things that you guys take care of. Is there someone that has an opioid antagonist nearby? What's their alert? We don't want them dying, but even mentioning getting those legs up when they pass out, that alone I think will do wonders. And I've just seen that so much.
Yeah, it reminds me, I think almost a year ago we had a webinar on wound care, and there was a lot of discussion about the challenges of people being on their feet a lot, needing to move around a lot,
Yes. Yeah.
temperatures, poorly fitting footwear, as well as, maybe there is something about certain substances and vasoconstriction with stimulants.
Yeah.
Question, what type of swab is used to detect syphilis from a skin or chancre?
Great question. Doesn't exist. There
Doesn't it?
is no swab we can to diagnose syphilis. So this is what's unfortunate sometimes. There is a term called dark field microscopy, which you might have learned many years ago. No one does it. I would say is that if you see an ulcer, what you're really doing is you're swabbing for HSV, and routinely does HSV 1 and 2. And if negative, you're thinking about syphilis. But really, that patient, you're going to test them for syphilis if you can. And if you see that heaped up ulcer, it's painless. I would try to treat them for syphilis right there and then because you might not get another opportunity.
Great point. And of course, it's a different swab for HSV and a public health rec.
Yes, yes, it's a viral swab. That's correct, and a public
Yeah.
health recommendation. Yeah, yeah,
Another great question we see a lot, dental abscesses. I know you could talk about, and
yeah,
again, going
yeah,
deep, but
yeah.
buccal dental abscess infections is the question.
Yeah, I would say this is that we know that people with a history of drug use, specifically meth use, are at risk of infections. And what I often say is that yes, antibiotics might help a little bit, but sometimes those tooth need to come out. And so I think what I would say with this, a few things. One is rinsing with salt water probably will help decontaminate that area. So that may be like an easy thing you can tell your patient, telling it 3 times a day, after meals especially. The other thing I would say though is you let the patient know if the pain becomes real bad, they go to the hospital. And this is one thing where it's an emergency room that an oral maxillofacial surgeon needs to take care of it. It's very unfortunate that in patients that are struggling, that oftentimes dental care is not covered. And we only treat them when it gets so bad. The only thing I'd say is if you're seeing a fair bit of that, a lot of times there's schools, dental schools that will often have like extremely cheap or exceptions for people that need dental care. So think about that. Wherever your practice is, where's the local dental school? I was in Oshawa before, and I think it was $30 for a cleaning.
Yeah, I've sent people to the U of T dental school. There's
Yeah,
a way, but I agree the care is fantastic.
yeah, yeah,
And it's a really, really great resource to think about. Um, Vaccines.
yeah.
So if someone has been diagnosed as Hep C positive,
Yep.
They should be eligible for hepatitis A and B vaccines through the provincial program.
Yes. Yep. Yep. Yep.
Just making sure around, from what I've heard about referring people back to primary care, some of us don't have vaccines in
Yeah.
our offices, um, and all of the sort of public health stuff to go through that. So anyone should be able to order that from public health if
Yep.
they order any other vaccines,
That's
correct?
correct. Yep. That's correct.
Yeah.
Yep.
And that's probably something that we should really be thinking about at a whole different level is just how to promote vaccination for those
Yeah,
things.
yeah, yeah, true. And you know what I'll say, like I just want to think big picture that Hep A and Hep B, getting those as an adult, I really think that killing people is unlikely. I if I had to choose between the two, I want to instill of testing for those things and diagnosing like chronic Hep B. I think that would be a lot more than ideally I want to be a raise awareness of vaccine, but I don't want to I don't want to focus too much like we need to vaccinate them. It's
Right.
that we need to diagnose these chronic conditions, I think is a bit of a priority. But if we can vaccinate them, let's do it.
Um, I know we have a minute. Public health contact tracing.
Yeah.
What will public health do for
Yeah.
what kinds of tests?
Yes, yes. So for chlamydia, gonorrhea, HIV, syphilis, they will contact the person. They'll tell them to contact people, and they can also ask if they want to do anonymous testing. Now, that being said, sometimes they can't reach the patient, and I'm
Mhm.
probably not going to assert too much. But what I tell patients is that if I diagnose them with a chlamydia, gonorrhea, HIV, syphilis, I'd say like, look, if you can let your partners know, I think it'd be very helpful. But public health, I'd say, will do their best. It's region specific. Some regions are a little more active. Some regions have a lot more things to worry about. So it is region specific, but they generally will try to reach out to the person, let them know, and then we'll ask them to let their partners know. And if they want, public health can do anonymous contact tracing if they have to discuss with the patient.
Okay, great. Remarkably, or maybe not, because you speak so quickly and
Oh, I'm so
efficiently.
sorry. I know I get
No,
excited.
no,
A lot of content.
I think we actually covered the questions. I'm just doing a look back. There were a lot about the lab recs and some frustration about what can or can't be done on the back end. Oh, well, I see one more is the only reason not to start PrEP before HIV testing so that they aren't undertreated. Yeah, I think that's
Yeah,
true.
that's correct. I'm just going to reword that is that we don't want someone on that has HIV getting the PrEP medication because the PrEP medication is like partial full treatment. So we would be partially treating someone, and that could cause resistance. So not the end of the world. And I'll give you one scenario. You have a patient that says, I had a high risk sexual exposure yesterday. That patient would be on post exposure prophylaxis. We would say, go to the emergency room. They're going to give you HIV pills.
Mhm.
Let's say if a patient says, a week ago, I had a high risk exposure. I think I have HIV. You check them, it's negative. What do you do? If that's a very high risk person, we would actually say, listen, you're having high risk sexual activity. We'll put you on pre exposure right now, knowing you could still have HIV, but we got to get you back in a month's time to test you. This may be a little confusing. Just understand there's an algorithm for everything. If you're uncertain, I would send them to emergency room or someone to get like, hey, look, let someone else go through what needs to be done if you don't feel comfortable. I don't think that's something to take on yourself, but saying, listen, you have a high risk exposure, go to the emergency room, discuss with them. I think that's very reasonable.
Yeah, no, I think, I mean, that originally came up in, the sexual assault care world in different scenarios. And I,
Yep,
I agree. Every emerge should have a process now for
yep,
thinking about whether it's needle stick injuries or anything
yep,
else. So
yep, yep.
that was fantastic. Thank you so much. I'm so glad that we're going to have these slides so everyone can turn the speed on their audio down.
Yeah.
I usually listen at 1.5. I'll be listening at 1.75. That was really, really useful. Thank you. Love the takeaways about the practical things. OTN consults, people can find you on
I'm
OTN
around. Yeah. OTN
website.
guys, I am around. I respond within 24/7, thoughtful stuff. And it's my pleasure. I enjoy it because I think there is so many questions. The guidelines can be confusing. So yeah, very happy to help. Again, sorry about the speed, but there was a lot I wanted to cover. So yeah, slow me down when you re-listen.
No, I didn't want to because I wanted you to get it all in. Thank you so much, everybody. Please, please fill out those evaluations. They're really helpful for us. And It usually takes us a few days to get the webinar and slides posted. I'm sure everyone will want to relook at them, share them. This was a really great reminder about all of the things that we can be doing actually without a ton of extra effort in our clinical settings right now that can have a pretty significant impact.
Yeah, great.
Thanks.
Okay. Thank you so much, guys. It's been a pleasure.